Okay, now we're going to go through platelet mapping, which represents about 80% of the clot. And this is where we're going to get to your question, okay? And see if you agree when we go through this. Platelet mapping is the only assay that analyzes platelet inhibition with hypercoagulability and drug resistance. Okay, that's a lot to say there in a sentence. When you give a platelet inhibiting drug, first of all, you want to make sure they're hypercoagulable to begin with on the platelet side. Okay? Because if they're not hyper and you give platelet inhibiting drugs, now you can put them at a risk for hemorrhage. Okay? And then we want to see, once we give them the drug, is the drug even working? Okay, so AHA guidelines post-stent, their society says aspirin and Plavix post-stent every patient. Every patient gets 325 of aspirin and 75 of Plavix. Every patient. So my question to the cardiologist is, hey, we all metabolize the drugs differently. How do we know that's the right amount? And they have no way of knowing, except with platelet mapping. This is what the mapping assay actually does. We look at two sides of the platelet. We first of all look at the adhesion capability of the platelet. This is what aspirin affects. And we use the agonist, arachidonic acid, to check that. Then the other part of the assay, we want to know what's the functionality of the platelet. Yes, sir?
Is this distinct from the TEG, or is this part of the...
This is another assay that runs off the TEG instruments. We just use different reagents.
So I would have to order both in order...
Yeah.
If you order TEG platelet mapping, you get everything you need. If you order basic TEG, you don't get the platelet mapping.
Yeah.
Oh, okay.
Yeah.
It's like ordering, I don't know what it's like. But
So for
something at a
Plavix, we
restaurant-
have to order the TEG platelets mapping.
TEG platelet mapping, yes. If it's on aspirin inhibitor is around.
Yeah. If it's not around, we don't have to do
Just
mapping.
basic TEG.
Basic TEG.
And so what we're doing with the functionality assay is we're using the agonist ADP. Okay? And what this test is going to give you is an in-depth risk assessment of a patient's hemorrhagic or prothrombotic state. This is a study done by Doug McCrath, and what he did is he used MAs and not Gs. G, again, is a calculation from MA. But what he shows here, he put the MAs into 4 different quartiles. And what we see here, even though this third quartile is in the normal range, okay, you still had a high number of ischemic events occurring from that. So in your third and fourth quartile, that's about a 70% predictor. Now what's interesting about this slide,
Where's your normal range line?
the normal range is 50 to 70. 50 to 70 millimeters for MA is the normal range. Okay.
What's the timeline of the risk? Is it annual risk, is it lifetime risk?
That's a good question that we don't know. We just know that they are at risk. Okay, and in this study here, this was a 2-year follow-up study. Now what's interesting about this is McCrath is a non-cardiac anesthesiologist. And he did this on, it was 400 and some odd non-cardiac patients. Now Paul Goebel, who's an interventional cardiologist, conducted the same study on his patients post-stent. And the beauty about Goebel's study was he came up with the same data. 70% predictability in the third and the fourth quartile.
Wouldn't you expect some changes if you're doing a procedure that's going to affect the endothelium of the vessel wall?
No, because eventually that will repair itself.
Yeah, but
I mean, on a stent, okay, the stent's going to damage the endothelium, right? Then eventually, though, the endothelium will grow into the stent.
yeah, but you're measuring this after the stent.
Right.
Is this immediate? The way you stated it sounded like immediately after the stent.
No. This is post years follow-up.
Oh, okay.
Yeah. This is like 2-3 year follow-ups on these patients. So the point I'm trying to make with these two studies is, no matter if it's orthopedics, OB, trauma, ED patient, cardiac, neuro. Hemostasis is hemostasis. Okay. The application for this is on all patients, not just cardiac. So what the mapping allows us to do is individualize, allows the clinician to modify their interventional treatment and individualize it for each patient's response mechanism. And that's what's important. To just give an empirical dosing of drug because a society says this is the way to do it does not mean that it's going to work on that patient. Remember the G value. It indicates the clot strength to withstand the shearing forces circulating blood flow. This value will quantify your risk assessment for individual patients. And again, we've gone over this already. Bruce Spies, Linda Shore-Lesserson came up with this in their papers, and Gerbil and McCrath came up with this in their papers. So in looking at the ADP assay for functionality, we take the patient's baseline citrated KO and G value.
I'm sorry. Would you review?
I'm sorry.
Would you review just briefly again the determinants that the things that are important to making whether the G's can be strong or not, whether it's going to be the lower value or the higher value?
I don't know what you mean by review that. The TEG's going to give you a value for G. Okay. And you have normal ranges.
Right.
Okay, we're going to get to that in the next slide, okay? So we're going to take the patient's baseline G value or clot strength, multiply it by the percentage of ADP aggregation. So this is your percentage of functionality of a platelet. We're going to multiply it by your G, and that's going to give us a net effective clot strength. And then here's what the calculation looks like here. Here's your normal ranges for G. So we've already identified and given you a window to look at to assess your patient's risk, okay, for clot strength.
And the major thing that's going to throw it over high is going to be hyperactive platelets, right? Predominantly.
Right.
It's hyperactivity of the platelets.
So let's take an example. We have a patient with a baseline G of 18. Remember, the normals are 4.5 to 11. So they are extremely hypercoagulable, okay? We give the patient Plavix, 75 of Plavix. We run the mapping and it shows that we have 50% inhibition from the drug. So in other words, we still have 50% functionality, right? So instead of our clot strength being 18, it's 50% of 18 or 9. So we've taken that patient from a risk for thrombosis and put them into a normal range. Okay? Next example. Same patient. This time the Plavix affected them 80%, only 20% functionality. 20% of 18 is 3.6. We've taken that patient from a risk of thrombosis and put them into a risk for hemorrhage.
So is those related? Like if I have a patient like that and they have a bleeding from Plavix, if I give him every other day or have those, that will make me...
Or a way to do this is maybe give them a milder ADP inhibitor. Like Persantine, Agranox, Toradol's a good mild ADP inhibitor. I mean, there's other avenues to go. Or Plavix every other day.
So it's dose dependent?
Yes.
I didn't know. Yeah, that's
Yes.
a good, yeah.
Okay.
Okay.
So the way to do it, and this is my argument with the cardiologist, not an argument, my discussion with them, post-stint, if they got a patient on 75 of Plavix pre-discharge, they should run a mapping.
Exactly. Yeah.
Okay, because did they put that patient in this condition? Because if that patient goes out, gets into a car accident, they may not be able to clot.
Or maybe we can say Plavix and keep range of G between 4.6 to 10.9.
Well, where we'd like to put them post-stint, we like to keep them in the lower side of normal.
Yeah, like
because remember, in Gerbil's and McCrath's study, 9.3 or greater is that third quartile.
Yeah.
They're still at risk, okay? So what we look at is anything less than 9.3, greater than 5. 5 to 9.3 is where we like to keep them, you know, and keep them in a safe spot. So again, you have a tool that you can measure this with that you've never been able to see before, never. And this is what Dr. Pantera has been looking at when he doses his patients. He brings them back, and sees where's he got his net G with these patients now. And he's had tremendous success. Tremendous success. Okay, here's another example. Same 18. Given Plavix, only 25% inhibition, 75% is still functioning. They got a net G of 13. We took them for thrombosis and left them there. These are the patients that need stenosis. Okay? So just because you give them the drug, it does not necessarily mean you have them therapeutic.
What about if I increase the dose? It doesn't help? Like 150 a day. You said 75 again.
It may. It may. Okay? All you can do is try it, run another mapping right after.
So is this the way the results come out in terms of the platelet mapping? It will give you
Actually, it will
results
not
of
give you
percentage.
a net G. I'll let Dr. Hewitt address that, how it comes out. How's the report look?
Well, it does. I think we did change to say net G. It used to say net clot strength.
Okay.
I think we have changed it, or we're going to change
By
it.
number?
And it'll give whatever the number is. Yeah, it'll give that.
Yeah.
It's on there. If you order a platelet mapping, if you don't order platelet mapping, there is no net clot strength. There's just the clot strength.
Yeah, because the number it make a lot of difference.
Oh yes, oh yes.
Okay.
Tim, you might want to mention, Dr. Aziz had one patient in here last year, February or March last year, I think, who came in with lots of microthrombi, all sorts of weird symptoms, and her G was 26. And he threw everything he could. He didn't use Integralin because he knew he wouldn't use that outpatient. Everything else, it got it down to about 24. Some patients are resistant no matter what you do. So sometimes it doesn't work.
So why would you order the TEG without platelet function?
Well, it's a good question. Sometimes you just want to, if these patients are not on any platelet inhibitors or drugs of that nature, their basic TEG is fine, just to see where they're at to start. If they're hyper to start with, then you need to follow up with them, put them on some inhibition or anticoagulant, depends on where they're hyper, if they're hyper on thrombin or if they're hyper on platelets, or both. Okay, and this gets to your question, geez, do I put my patient on Coumadin and an anticoagulant or an antiplatelet drug? I mean, these are clinical decisions that the physician needs to make, but we're trying to show you where their hyperness is at. And we've got quite a few people that now are starting to mix anticoagulants and platelet inhibitors because now they can measure it.
Yeah.
Okay, now they can measure it. Before they were just blind to it. They could see the anticoagulant, they couldn't see the platelet.
Yeah, I agree. So what I'm saying, we give example, if the patient has a valve replacement, I put him in Coumadin, it works, right?
Right.
So now, if I put him in antiplatelets to like Plavix, I will increase his risk of bleeding too. So
Maybe.
Maybe or maybe not.
Right? You don't know. Let me ask you, you have a person on a valve, okay, and you put them on Coumadin, how do you know it's working?
And now I do that to see if Coumadin work or not.
Yeah, but what I'm
How
saying
about-
is, even though you're therapeutic on your Coumadin,
Yeah.
okay, with the valve patient, how do you know the platelets aren't super hyper?
That's what I'm saying. Yeah.
Right. But even though they're therapeutic on the Coumadin and their platelets are super hyper, they're going to have an event. The Coumadin will not help.
So, okay. So TEG is a primary test.
TEG is a very good tool to use. Yes, sir.
How,
You have to order the
you get
application.
patients who come in last day with TEG.
All my patients need tags.
How long do you wait before you do another test to see whether or not they're sensitive to it?
A couple hours.
Oh, wow.
Yeah.
Really?
Yeah, we'll see. We'll see. TIA, aspirin, is aspirin enough?
Yeah.
If they come in TIA, I run a TEG right away and see if the TIA is stemming from thrombin or if it's stemming from the platelet. If it's stemming from the platelet and you got a G value greater than 16, aspirin is not going to be enough.
So Dr. Hoyt, maybe we have to put in a stroke protocol TEG as a test.
Yeah.
We have to put that in the protocol.
Again, it's a way to assess.
Yeah, we have to do in the
To
protocol.
give you a window to look at to see, geez, what's really going on with this patient? Yeah. Yes,
Is
ma'am.
anybody doing any studies in relationship to that, like in putting the antiplatelet and anticoagulants together? Or
Yeah.
you guys are looking at that?
Yeah, absolutely.
Awesome.
I know Dr. Pantero's doing it. You know, I mean, we have to protect these patients. And all I'm saying is what you're using now, or have been using, standard coags, will not help you with these patients. That's why we think the TEG's real importance is on the prothrombotic side. We can help these people now. Once we know they're at risk, we can help them. Because they're not going to come to you with symptoms. They're already going to have their event. Okay? For the aspirin assay, all we're looking at is the percentage of inhibition. That's all we care about. Okay? And we use arachidonic acid to do this assay. And we know that if they're 0 to 20% inhibited, they're non-responsive at that dose. Aspirin is dose response related. Where we like to see them is anywhere in here. That's where we like to see them. They're mildly responsive. If they're greater than 80%, they are highly responsive and they're way overdosed. My uncle had a dual stent put in at Kaiser, and he just happened to visit me, and about a week post-stent, I said, I want to do a TEG on him, platelet mapping. I found out that, first of all, his 75 of Plavix inhibited him only 12%. Wasn't working. And his 325 of aspirin had him 98% inhibited. Way too much. So I called his cardiologist and I said, you know, do me a favor, take him down to 162. And then let's see where he's at. I said, as far as the Plavix, it's not working, it's not protecting him. He says, well, what do I do? And I said, well, you got a couple of choices. One, my uncle was also on Lipitor. Lipitor is a statin, as you all know. And it uses the CYP3A-P450 pathway in the liver to molecularize and release. Plavix needs that same pathway. So if the statins are bound to that pathway, Plavix cannot get through. Plavix must get through on its first pass or it will not work. Plavix has got one other pathway to go through, and you guys have probably read about this, the 2C19A pathway in the gastric region. Okay? If a patient is on a PPI, which most patients are, okay, and they're bound to that pathway, Plavix cannot get through, or may not get through. I shouldn't say cannot get through, it may not get through.
But decreasing.
Okay, so what I suggested to my uncle's cardiologist, do me a favor, put him on Crestor, okay, and then keep him on the Plavix.
What's about if you change the time, like Plavix in the morning and Lipitor by night? Still?
Depends. It depends on the patient. I can't give you a yes, no, black or white, okay? But when I tested my uncle, it was not working on him. That much I knew. So he wasn't being protected. So he changed the statin to Crestor, which is a totally different pathway in the liver. And then the Plavix worked and got him 50% inhibition. Perfect.
So it's a metabolite of the Plavix that's active and not the actual drug.
Correct.
So because it's essential for it to get through the metabolism for it to have its effect.
Right.
And so you can competition for the enzyme, and it doesn't get metabolized to the active.
There you go. And then, have you heard about the drug Prasugrel out there? That's a new, quote-unquote, Plavix.
FX.
Okay? And that works the same as Plavix. I don't care what the Eli Lilly people say. Because they say it works on everybody. We have documented cases it does not work on everybody. And we can prove it to them with mapping. Okay? So, what we're looking at with the aspirin assay is aspirin, as you know, is going to knock out cyclooxygenase, which will inhibit thromboxane. But what it also does is it sends an indirect signal to glycoprotein 1B receptor on the platelet to turn off. This is your adhesion receptor of the platelet. Okay? So the way we counteract that in surgery is if we have a patient that's greater than 20% inhibited from aspirin going into a surgery, if they're bleeding at the end of the case, we recommend the drug DDAVP. Okay, the reason DDAVP is Again, like I said earlier, it releases the von Willebrand's factor. Von Willebrand's will go straight to glycoprotein 1b and turn it on. Okay? So now the platelet can stick to the vascular wall. All right? We are not trying, we cannot reverse the effects of aspirin. What we're trying to do is attenuate to turning on glycoprotein 1b. Your ADP and GP2B3A receptors, these are your functionality receptors of the platelet. Glycoprotein 2B3A, that receptor is activated by the most potent activator of the platelet, which is thrombin. Okay? Once these receptors activate, they tie together with the other platelet, same receptors, with fibrin strands here. All right? Then ADP, what that does is it sends signals to other platelets to come. So if this receptor is inhibited, other platelets don't come. And if this receptor gets inhibited, it sends a signal to glycoprotein 2B3A to turn off. That's why these patients bleed. Okay, because the functionality is severely compromised. Now, the platelet mapping assay.
So the
Yes,
aspirin
sir.
affects both the adhesion and the functionality?
I'm sorry?
The aspirin doesn't not only affect the adhesion, or it's the functionality as well?
It affects a little bit of the functionality, but not a tremendous amount.
It took my wife's net G down, or G down to by about a half, you know, from 10.5 to 10 or something like just
Yeah.
aspirin.
It has a little bit of effect on functionality, not much, and it's mainly on this receptor right here. Okay. Now the platelet mapping, when it's looking at functionality with the ADP assay, we're looking at this combination in net. So if you have a patient on Plavix and integralin, integralin is going to affect this receptor, Plavix is going to affect this receptor. We cannot tell you what percentage of the platelet is affected by Plavix, what's affected by integralin. We just give you the net. The net effect. We can bypass that. Enzymatic inhibitors. We see Reflutin, Angiomax, all these drugs here. We see the heparins. Protamines shouldn't even be on here. We do see the coumadins. We see activated protein C. Now, any of you dose your patients with Lovenox? Use Lovenox on any of your patients? The TEG is a great device for measuring the therapeutic effect of Lovenox. It sees it perfectly. And it's more accurate than a factor 10A assay instrument. And I had this discussion with the cardiologists at Stanford. They said, Tim, why doesn't our anti-10A correlate with your TEG-R value? And I say, because your 10A is incorrect. They looked at me like, well, who are you to tell us that? And it's true. Lovenox has two pharmacological pathways. 2/3 of Lovenox binds to 10A. Where does the other third bind to? AT3. Right. So your anti-10A assay is strictly looking at the 2/3 effect. The TEG-R value is seen in both the 10A and the AT3, the net effect. Now Stanford uses the TEG to monitor their 10As with Lovenox dosing. So it's a very good assay for seeing Lovenox.
So in place of their 10As?
No, when they're dosing Lovenox for therapeutic advantage, they're running TEGs. To just isolate 10A, they're still using their 10As.
So if you had a patient on a dose of a prophylactic or a therapeutic dose, you could run and get an R and correlate that?
Yeah, because where you want to have that R is at the high end of normal. So the normals for 5 to 10 minutes. So you want to get them at about 10 to 12 minutes.
For therapeutic?
For therapeutic, yes.
And for prophylactic? Because sometimes we do give them prophylactic dosing of Lovenox.
Right.
We don't have a clue as to how well.
How much word work?
Run a TEG.
Yeah.
Find out. It'll show it perfectly. And the beauty about the TEG, remember, we can run a plain cup and a heparinase cup. So the heparinase will take out the Lovenox, show you where they're at with no Lovenox on board, and the plane cup will show you where they're at with the Lovenox on board. So your heparinase is your control, which is really cool. You have a control.
So for Lovenox, we don't, I mean, like, we can order TEG after we treat the patients?
Yeah.
Right?
Yeah.
And if it's normal, we continue the same dose, we don't have to do anything extra, I mean, we'll be okay.
Right. Or if you're doing how about a Lovenox Coumadin bridging?
Yes,
How are you monitoring that?
So you get a
INR? INR's not going to...
we don't want it, we give
INR's
Lovenox.
not going to show you
No, we
Lovenox.
do Lovenox and we give Coumadin until INR go up and you stop Lovenox. That's what we do. Right?
Yes, sir.
Right?
So they bleed to death.
Can you give us some of the values that we're gonna see on these lab results as we're going along here, so we know what you're talking about and how we're gonna read them? Looking at these.
Yeah, we will when we go through the case studies. Okay? And we'll get to those in a second. Just bear with me a little bit. We're almost done with this first part. Okay, the platelet inhibitor drugs, we see your Riopro and Targoin agrostats, we see your Plavix and Avenue Prasugrel, we see your Persantines, Toradol, aspirins, your Agronoxes, drugs of that nature there. And then we have a new assay. Dr. Hewitt, should I go over the rapid or not really?
Most of the folks here aren't going to be involved with that.
Okay.
They will in some of the trauma situations.
Okay. Do we have trauma people?
We do have a couple.
Yes.
We do, okay.
We don't like them very much, so.
Okay, well, let me show you what Rapid does. Rapid is a faster TEG. A TEG, by the way, takes about 30 minutes to complete, okay, from start to finish. So a rapid TEG takes about 10 minutes. You just get the data that much faster. And with the basic TEG, we're activating the sample with kaolin. With rapid, we activate with tissue factor and kaolin. So with the kaolin, you're activating the intrinsic pathway. Rapid, we're activating both the intrinsic and the extrinsic pathway. So it just comes quicker. The problem with the rapid is that we lose sensitivity in the R value, okay, because we're bombing both pathways. But what the rapid actually enables you to do is it correlates beautifully with the basic TEG in your angle, your MAs, your Gs, and your lysis. It sees all of that just like a regular TEG. What it does not see is the R value, so what we replace the R with is a TEG ACT, and you're familiar with ACTs, okay? We correlated the ACT and submitted our data to the FDA. We correlated with hemochrone, which is used in quite a few hospitals. This slide here, you see a basic TEG with the little R stem, okay, and then the rapid does not have the stem. But you see how everything else on the tracing correlates, the parallelness of the angles and the width of the MAs? The only difference is you don't have an R stem. That's a hyper one. Here's a platelet dysfunction curve. Again, it shows it perfect. So at about this point, on a rapid, in about 3 minutes, I know exactly where the rest of the tracing's going. The anesthesiologist in cardiac surgery, they use the rapid TEG for their on bypass run and their post-protamine runs. That's where they use it. Okay? Trauma, they use it all the time in trauma. In fact, that's where we did most of our data collection was in trauma. This here is a primary fibrinolysis case, and again, it shows it.
Now, the caveat with a rapid TEG is the other studies, the sample has to be drawn and used and run within 2 hours. After 2 hours, we can't guarantee it's any good. The rapid TEG has to be drawn in a syringe and on the instrument within 4 minutes. So it's a little tricky. We don't really recommend typical patients on the floor getting a rapid TEG because it doesn't take much to make it worthless. Plus, you have to call the lab ahead of time and say, guess what? You want to send a rapid TEG down. You need to give them about 5 to 10 minutes to get the reagent ready.
Anytime a TEG is ordered, you should call the lab just to notify them because they've got reagents they have to prepare, things of that nature, their data they got to enter into the computer. And so just give them a little bit of notice and then send the sample.
How does it work for outpatients?
They have to come to this lab, come right here. Works fine.
Is insurance covered there?
Yes.
Like if I have a patient in stroke and he's have a private insurance and the right TEG, do you pay for it?
as far as I know, we haven't gotten any denials
So,
for outpatient, as far as
and
I know.
Medicare, of course.
Yeah. As far as I know. Who knows?
Yeah, there are CPT codes.
We'll talk to the
all
president about it.
associated with this.
And see if he's gonna cover it.
And hence
for us.
reform, Brown.
There's even physician interpretation codes.
He has to put more money in health reform after
That's
that.
right.
Okay, let's take a look at this case here. It's a hard case. ER, patient came in with chest pains, put on Lovenox. Already on aspirin 325, Plavix 75 millimeters. Is this patient at a high risk for bleeding? Yeah, right?
Oral insulin.
Hey, here's the baseline. Okay, I'm showing you two tracings here. The white tracing is with a plain cup. The green tracing is with a heparinase cup. You see how we see the difference in the effects of the Lovenox? See where the two curves split? Okay, so without Lovenox, they're right here. Green tracing. With Lovenox, they're right in here. Okay, first of all, they have a net clot strength of 7.7. They have a delta of 1.1. So this here is normal. This is normal. This is normal. Patient's not at risk for bleeding.
You know, on your graph of patients that got Lovenox, the peak effect was at 2 days.
Right.
So is this an ER study? And
This-
is it going to benefit the ER? I mean,
As it peak effects in 2 days, then, you know.
Right, right. We'll see Lovenox, the onset of Lovenox within 20 minutes. We'll see
20
it.
minutes,
Yeah.
should be 20 minutes.
Yeah, we'll see the onset within 20 minutes. The peak, as you saw, and we're acute to, is about 2 days. But as it peaks, we get closer and closer to where it's actually at.
Since it's a sub-Q administration.
Right.
You're gonna have a slow, just from the network effect.
What's the half-life? I'd say?
But it's effective for 20 minutes, right?
Yeah, we see an effect of it within 20 minutes.
I mean, it's a full effect, though.
Right, I agree, I agree. Okay, we did platelet mapping. This patient was on Plavix, right? No Plavix effect. See, 94%, 95% still functional on the platelets. Okay, so the Plavix they were on is not working. Is the aspirin working? Oh, yeah. Yeah, 98% inhibited from aspirin. Okay. Here's post-protamine. Patient was oozing at the end of the case. All they gave was a little bit of DDAVP to offset the aspirin. Patient dried up. So again, no blood product was given, just some DDAVP for the aspirin effect. And the Plavix wasn't working, so platelets were functioning fine. ICU patient, patient bleeding, no TEG run, prolonged PT, PTT, you would expect that. Patient given 2 platelets, 2 FFP, and 10 cryo. Patient continued to bleed. Why? Well, let's get a TEG. That's what it looked like. LY30 greater than 8, right? Got a hypo-R, hypo-G value. Primary fibrinolysis gave Amicar. TEG normalized, patient stopped bleeding. So instead, they kept throwing product at this patient, kept bleeding. Hey, let's get a TEG, let's find out why are they bleeding. And it happened to be primary fibrinolysis. Trauma case, 24-year-old, multiple knife wounds. Baseline mapping showed no inhibitions on the platelets. Surgery performed, patient continued to bleed. Patient given FFP, cryoplatelets. Patient continued to bleed post-transfusions. Why? Let's get a TEG. TEG's normal. Our delta is normal, 0.7. We have a net G, which is normal. Everything's normal. Mapping, there's no inhibition. Okay, got a net clot strength, very good. Aspirin, no aspirin inhibition. Patient taken back to the OR, surgical bleeding found. But yet they kept throwing product at this patient. That was the reaction. So instead of throwing the product, maybe they should have ran a TEG to begin with.
How long, if I have a patient in ICU and he's bleeding and I want TEG out, how long I got it back?
Takes a half an hour to run the assay, and if you send a blue top tube, the lab's got to wait 15 minutes from draw time before they can start the sample. And it takes about 30 minutes from that sample point.
So the result will be within 45 minutes?
Yes.
And in the ICU, once ISS comes through and fixes it,
Fixes
in the ICU and in the CVICU and in the ORs, you can actually see the curve and see the results right off the instrument.
In real
So you
time.
can call right away?
Yeah, or you can call it up and see it happening.
Yeah, because if the patient's surgical bleeding, 45 minutes is a lot.
No, I agree. I agree
That's what
with
I'm
you.
saying, yeah.
Yeah. So while this curve is forming.
So you call right away?
No, you don't. Hold on a second.
Yeah.
You can pull it up on the computer in the ICU.
Ah.
You can see this forming in real time. So if you're seeing a long R and a shallow slope and a narrow MA, you have coagulopathy. If you're seeing a normal curve,
I call the surgeon.
surgical or adhesion, DDAVP or surgical. Okay. Next case, stent restenosis, patient's on 81 of aspirin, 75 of Plavix, patient has an ischemic stroke. Why? Well, hyper on the thrombin, hyper on the clot strength, platelets. Okay, what's the Plavix doing? 100% functionality. Plavix didn't touch them. Okay, how's the aspirin doing? Aspirin didn't touch them. Zero inhibition. This patient is so hyper, of course he restenosed. And he was hyper both on his thrombin side and his platelet side. Okay? Now here's how we can help these patients. If they're hyper on both ends, the thrombin side and the platelet side, the strategy is put them on an anticoagulant, Lovenox or heparin, preferably heparin. You get an effect right away. If your R time lengthens and your MAs narrow, then we know it's thrombin base causing this hyperness. If your R time goes out, you decrease the production of thrombin, and your MA stays wide, we know it's platelet based. Okay?
Now, why was this one done with heparinate? Usually on heparin also?
Don't know why, Joe, to be honest with you. Good observation.
So a patient like that is strong, so we have to try Lovenox or Coumadin, right?
No.
Coumadin doesn't work
No,
either.
no. I'm on heparin,
Yeah.
okay?
Okay.
Because you can reverse the heparin very quickly with protamine,
Ah,
if you
okay.
need to, right?
Mhm.
Okay. You put them on heparin, you lengthen the R time. If this MA stays wide, we know the hypercoagulability is platelet based.
Oh, okay.
Okay, then they need to go on platelet inhibition. Okay, then you know, right?
Yeah.
If this widens out or lengthens out and this width narrows, then we know it's thrombin based and they need to go on Coumadin, long-term Coumadin, protect them. Okay? Here's another one, ICH, patient had a hemorrhagic stroke, patient's on 325 of aspirin, 75 of Plavix, platelet mapping is performed. Aspirin lowered to 81 milligrams, Plavix lowered to 75 every other day. Why? Okay, they're not really hyper to start with. They have normal thrombin production here, and their G value is 6.4, normal. Okay, they're not at risk, low risk. The Plavix has got them 96% inhibited. So they've got a net clot strength of 0.3, which is absolutely nothing. Okay? And let's see what they got here. Aspirin, 95% inhibited from aspirin. So not only were their platelets not functioning, they couldn't stick either. Of course this person had an event. Remember that? So So what they did is they lowered the aspirin and the Plavix every other day on this patient. This is post the drug titration. See how everything starts to normalize out now? Perfect. So every other day on the Plavix, instead of 95%, they have, instead of 4% aggregation, they've got almost 60% aggregation. That's good. They can clot. Okay, femur fracture. Patient on 81 of aspirin, 75 of Plavix. Do we take this patient to surgery? Do they go to surgery right away, aspirin and Plavix patient?
We have to wait for 7 days.
Right, 5 to 7 days wait, right? Okay, so what do? You put them up in the hospital for 7 days, keep them in traction, right, and wait for the drugs to wear off?
Here's the TEG sheet.
Okay, what did we do? They ran a TEG. Here's what they look like. They have a normal thrombin production and they're hyper on their G, right? What's the aspirin doing, or what's the Plavix doing? 99% functionality still. Aspirin, the Plavix isn't even working. So they still have a net clot strength of 13.3, they're hyper. Okay? How's the aspirin working? Aspirin's not working at all. Take them to surgery right now. They will not bleed due to the drugs.
And we need to find out another medication to put them after that.
You're exactly right.
You hit too far.
Or that patient could have been on a statin.
Yeah, or
Okay.
a statin, yeah.
To where the Plavix isn't working, and then you may have to up his dose of aspirin. Okay, but post-fracture fixation, this patient's at risk for throwing clots. Okay, and this is where the orthopedic surgeon will put these patients on Lovenox post-procedure. So now you need to monitor the Lovenox dosing on these patients. Because the Lovenox should lengthen the R out, but is it going to narrow the MA? If it doesn't, then you got to help these patients with platelet inhibition.
And when these patients come in to the ER, that's a great time to order the platelet mapping.
Yeah.
Because the surgeon already has that information by the time he gets the call. And you can bet that
You guys, you don't order that.
more than half these patients,
I could have ordered one yesterday.
more than half these patients can go to surgery virtually immediately.
Immediately.
Guaranteed.
So, but we order if the patient have Plavix can aspirin, right?
Or
Aspirin doesn't matter.
and if they're not on platelet inhibitors, order one anyway. Make sure they're going to be okay for surgery, right?
Yeah,
Old,
because they
especially
could
the old
be-
patients.
They could be on these quote-unquote nutraceuticals, omega-3s, fish oils. You just don't know. And they do affect the platelets. Okay, I believe this is the last one. Open heart, 64-year-old woman, MDR, AVR, cabbage times by piece of cake procedure. We lucked out, had good renal function, good liver function. Okay,
Well, that patient is not in this hospital. Yeah. We don't know that patient.
Actually, this is a patient from this hospital. Diabetic and obese.
Well, there you go.
So with what you know now, would you expect this patient to be hypercoagulable, normal, or hypocoagulable? It's based on what you see here. Hyper, you're all correct. Here's your clues, diabetic and obesity. Okay? Here's your baseline. The red tracing, and you can see this when you pull it up in the ICU, we can overlay what a normal curve should look like. Okay? To give you a visual, a quick visual. If they lie outside the normal, they're hypercoagulable. If they're inside the normal, they're hypocoagulable. Okay? So she's hyper on her thrombin, hyper on her platelets. Just like we figured, right? How's her mapping look? So 85% functional, so she's got a net G of 11.4, perfect. So she's still hyper on her clot strength. And her aspirin has got her 26% inhibited, so we may need some DDAVP at the end of the case. Okay, this is on her bypass run, and for you, you can see we got the ACT right here. Okay, now she's on bypass, so why does she have an ACT of 105? Should be above 500. because, as Joe pointed out earlier, we're using a heparinase cup, which will eliminate the heparin in the sample. And the beauty about this, what the clinicians love is, even though this ACT is not clinically correct, what it's showing you is where the ACT would be at if they were not on heparin at all. So we know the factors are not being consumed on bypass. Okay, that's the beauty of it. Plus it gives you the rest of the clot. So we know the factors are doing well and she's still hyper. Okay? Postprotomy. They ordered 2 FFP, 10 cryo, 2 platelets. Her factors are normal. Her fibrinogen is a little bit hypo. And see her clot strength is 85% of 5.2. 90% of 5 will run it off about 4.5, which is less than 5.3. She was bleeding. Okay? So Dr. Mendenhall was actually anesthesia for this case. We had a discussion. He says, well, geez, Tim, I want to go FFP. I said, okay. And I said, why? He says, because if I give the FFP, that'll give us more thrombin than the platelets. Yeah, you're right. Okay. So he gave 1 FFP, but he also gave the DDAVP for adhesion. Next slide. Post-surgical in the ICU, we run 2 samples. The green is the heparinase, the white is the plain cup. And what you're seeing is a little bit of excess heparin here. Patient was bleeding 80 an hour. So they gave 50 more protamine. Patient stopped bleeding. So we only gave the patient 1 FFP, DDAVP, and protamine. Stop bleeding, so we saved 1 FFP, 2 prior to that.
And that's the key. Those standard orders is so common. Give her, 10 of these and 2 of those and 16 of those. You don't need to do that anymore. You can see what the patient really needs.
Now we're using guided science now.
And that's how we were able to lower the usage of plasma, platelets, and cryo by 90% in the cardiac surgery program. 90% reduction.
Wow.
Well, that's
When they follow the TEG.
With increased safety.
Yes.
And patient
Everybody
outcomes.
wins
Yeah, the outcomes.
when they follow
actually,
TEG.
yeah, you save heart failure, you save pulmonary edema, you save a lot.
Money, days,
Dr.
money.
Hewitt, you remember this case? This is when we first started the TEG here.
One of the first ones we did.
47-year-old male, INR 3.8. Scheduled for paracentesis. They ordered 3 FFP, 2 platelets to lower the INR so they could take him to surgery in a couple of days.
How platelets lower the INR? I hadn't figured that out.
So I got a so Dr. Hewitt gets a hold of me and I said, well, why don't we just run a TEG? So he called the surgeon up, said, okay, we got this new test, yeah, okay, let's try it out. So we ran a TEG on this patient.
It's high.
A little bit hypo, okay, they're inside, but you see our thrombin is very good here, hyper. And our G at 4.8 is just above the low point there. Okay, but we got good thrombin here. That was the key for me. We have 73% functionality of the platelets, so that gives us a net G of 4.8. Okay? Just above the normal. And again, we have strong thrombin. How does the aspirin side look? 23% inhibition from aspirin. We may need DDAVP at the end of the case. So the surgeon goes, he calls me up because he asked Dr. Hewitt he wanted to talk to me to get educated on this. He called me up, I went through everything with him. He says, okay, Tim, I'll take this patient's surgery right now. But if this patient bleeds, you better be in that OR and have answers for him. Okay? How about if I just sit in the lab or in the
In the courtroom.
No, I'll sit in the cafeteria. If you have a problem, here's my cell number. Just call me. I'll come into the OR. Never got a call, did we, Dr. Hewitt?
Not a one.
Patient didn't bleed. No product. Patient was not exposed to the product. Okay, last case, and this is just my favorite case. This is with Dr. Kamina, Dr. Mendenhall. Again, another ho-hum case. AVR cabbage, redo ×5, diabetic, dialysis in the room. Okay, patients on aspirin and Plavix. Okay? So, here's the patient's baseline. Hyper, right? Normal thrombin here, but our G is 12.1, okay? Hyper G. We did a ADP, checked the functionality with mapping. Only 31% of his platelets are functioning. The 31% times 12.1 gives us a net G of 3.8. This patient's gonna, might as well hook up an IV line straight to the blood bank. They are going to bleed. Going to bleed. How's the aspirin doing? 73% inhibited from aspirin. Dr. Kamina, to his credit, said, let's delay the case. It's not emergent. So he delayed the case 2 days. Okay? As hemostasis-wise, the patient was not ready. This patient had been off Plavix for 5 days. Okay? Off Plavix for 5 days, it's still 69% inhibited. Okay, we waited 2 days. This was a Friday. We tagged her again on, we mapped her on Sunday. And here you go. 2 days later, the Plavix is starting to wear off. 80% functionality of the platelets. We've got a good clot strike now. Okay? Here's the bypass run. A beautiful ACT, but notice your G is starting to climb. See how your net G is starting to climb? The Plavix is wearing off now. During the procedure, it's getting less and less. She's becoming more hyper as the case is proceeding. Post-protamine. See where G is at now? It's in the 19s. Okay? And we ran a rapid tag, and the plain cup rapid shows an ACT of 136. And the heparinase one shows an ACT of 115. Patient's oozing a little bit. Dr. Mendenhall said, I'm going to leave the heparin on board to protect this patient from the hyperness. Watch what happens. ICU. See what that heparin's doing now? See how it's lengthening the R and narrowing the MA? This person's hypercoagulability is all thrombin-based. This person needs to go on Coumadin, long-term Coumadin, to protect them. Patient was not bleeding, no blood component given. Because they had the foresight to run the assay, it showed this patient was going to bleed. They weren't hemostasis solid, so they just waited a couple of days, delayed the case, and then the hemostasis solidified more, and they were able to do the procedure very nicely. No products given. Otherwise, if they did the procedure, they would have emptied the blood bank.
So you mean this basic hypercoagulation?
Yes.
His baseline.
Yes.
And the Plavix was working with him good. Why we don't put him in Plavix?
Well,
not common.
Well,
He said common.
Yes, because we knew that by lengthening this R time, this MA narrowed. So now we know it's thrombin that's causing the hypercoagulability.
Okay, not the Plavix.
Right.
Yeah.
Not the platelets.
Something you said earlier but didn't put quite in the terms that you taught me, and Phil taught me, was treat the R first. Treat the enzymatic side first. See if that works.
Okay. Because everything triggers off that. Right? Once you have thrombin produced, boom, everything triggers from there. So you treat the beginning of the TEG first with either anticoagulant or FFP. If it's hyper or hypo. Hyper, you deal with anticoagulant. Hypo, you deal with FFP. And see how that triggers the rest of this cascade.
One case I wanted to discuss real quick.
Yes, sir.
The most dramatic case I saw here, I happened to be standing there when it happened. And over-heparinization always happens occasionally. You can tell that this just goes like this, and then it comes out and looks like a little fondue fork. Okay. Way too much heparin. Doesn't allow anything to get started. Just overpowering everything. And we had a trauma patient here. He was 18. They think he was texting, of course. Flipped his car. Blasted his liver. Just terrible. Dr. Zulum and the trauma team and all the nurses did such an amazing job on this guy. They ended up actually having to cross-clamp the aorta above and below the liver, which is until this case, uniformly fatal. Okay, didn't kill him. But we're looking at, they'd taken him to surgery for hours and hours, taken him back to surgery again, had him in the ICU, ran a TEG because he started bleeding again. He started oozing, and what's going on with this guy? And it came out extremely long arm time, very, very low MA. And Rebecca Zubin was standing beside me while the curve was running. We were looking at him. Oh, look, that's heparin effect. Why'd you give him heparin? We didn't give him any heparin. He's a trauma patient. We didn't give him heparin. Well, liver damage, I said, this is, Tim and Phil taught me that this is endogenous heparinoids from the liver damage. The body produces these things. And give him protamine. They did, came back to normal within minutes. He actually left the hospital. He survived. Should not have survived. But this is an absolutely amazing case, stunning case, blew everybody's mind. And
It's auto-heparin, you know?
it was his own.
Yeah, it's the
heparin.
body producing heparinoids,
Which
which I see a lot in liver transplants.
So anyway, this thing works. This thing works like that.
I want to thank all of you for
No, thank you
coming.
very much.
Hopefully it was informative.
Oh, one more thing with respect to the platelet mapping. I'm sorry, remember the talk about the Plavix and the Lipitor and all that. The sexy thing now is the genetic resistance and testing for genetic resistance to Plavix and similar drugs. Well, you might not want to do the $4 or $5 or $1,000 or whatever test that it is, but you can see it for the $200 or $300 TEG. You can see the resistance to Plavix. If you know it's not a Lipitor or anything that's going to interfere with it, Plavix doesn't work, it's resistance. Use something else. Use Placenta.
So, do you have your talk on YouTube?
It's going up tonight.
Tonight.